Is this usable?
Yes, it is.
Okay.
Good morning, faculty, staff, students, and every other attendee. My name is Randalljellis, and about 1 year ago, I was awarded a $500 undergraduate research grant to assess the antidepressant efficacy of a drug called Dextromethorphan in the most widely used animal model of clinical depression, which is the 4-swim test. I'm not going to use this, that way I can go closer to the projector.
So, I'm going to talk to you a little bit about the current state of depression. Depression is the second most prevalent mental disorder in the world behind generalized anxiety disorder. It is extremely costly to American employers, costing between $24 and $31 billion a year in employee absenteeism and reduced work performance. Now, current treatments for major depressive disorder, your Paxils, your Prozacs, your Abilifys, your Wellbutrins, all focus on modulating the activity of 3 neurotransmitters in the brain: serotonin, dopamine, and norepinephrine. And these treatments are largely ineffective. There's a rule of thirds that's used to summarize treatment efficacy, as in 1/3 of patients never respond to treatment, another third of patients respond but subsequently relapse, usually within 1 year, and 1/3 of patients respond and continuously respond, and they are the lucky ones. Now, there is another neurotransmitter in the brain that has been largely neglected by psychiatric researchers. This is glutamate. Glutamate happens to be the most abundant excitatory neurotransmitter in the brain. And for the past 15 years, one glutamatergic agent, ketamine, has been shown to be a very rapidly acting, effective antidepressant. And this is in contrast to conventional treatments, which take between 3 and 8 weeks to start working in patients. Now, dextromethorphan is another glutamatergic agent. It's an NMDA antagonist, at a type of glutamate receptor known as the NMDA receptor. Now, dextromethorphan and its main metabolite, dextrorphan, happen to have greater affinities for all of the neural mechanisms wherein ketamine exerts an antidepressant effect. For examples include NMDA antagonism, sigma-1 receptor agonism, serotonin transporter inhibition, muscarinic receptor antagonism, and mu receptor potentiation. So, the goal of this research was to investigate the antidepressant potential of dextromethorphan in the most widely used animal model of clinical depression, which is the forced swim test. The forced swim test is fairly simple. You take a bucket of water, you fill it halfway. You put a rat in the water, you measure how much time within 5 minutes it's engaging in climbing and floating behaviors. Because when it's floating in the water, not trying to escape, that's considered the animal correlate of clinical depression, because it doesn't have the drive and motivation to escape from the water. So to elucidate this a little more clearly, I used male-adult sprayed dolly rats, 4 per group, because my grant was only $500, and so I could only afford 8 rats. The experiments were conducted in a bucket, like so. I got them from Home Depot, fairly simple. So, habituation. To get used to the aquatic environment, rats were placed in the water for 15 minutes so that way they could acclimate to the aquatic environment. Now, I used dextromethorphan at 30 milligrams per kilogram and saline, plain old salt water, as the control group. And these treatments were administered 23 hours after habituation, 1 hour before the test trial. So 1 hour after administration, rats were placed in buckets and recorded with a Canon Rebel T3i camera for 5 minutes. Then, 2 naive scorers watched the videos, one of them is present today, and they watched the videos and scored how much time the rats were engaging in 3 behaviors: floating, not trying to escape, swimming and moving around in the bucket, or climbing on the sides of the walls trying to escape. I was looking at immobility time because the idea is that if a drug can significantly reduce the immobility time of a rat in this test, it may translate to be an effective antidepressant in human beings. So I used a one-way ANOVA to see if there were significant differences between the mean immobility times between the swimming group, between the dextromethorphan group and the saline group, and a Krustal-Wallace ANOVA, a non-parametric ANOVA, was used if Levine's test showed significant differences in the variances. Additionally, a Cohen's D was employed to quantify the effect size between the 2 groups if there was a significant difference. So, I found that in the plain old one-way ANOVA, there was a significant difference between groups. And a Cohen's d ended up being 2.04, which indicates a highly significant effect size for dextromethorphan reducing immobility time in the 4-SLIM test. Levine's test did indicate that variances were significantly different, and so I ran a Kruskal-Wallis non-parametric ANOVA, which also found significant differences. And this is the chart. This is the parametric ANOVA. These are the means, and as you can see, the standard error of mean bars do not overlap at any point. That is how large of an effect size that I had. The standard error of mean bars do not even overlap. That is the significant reduction that I found in this experiment. So, the present study showed that dextromethorphan at 30 milligrams per kilogram statistically significantly reduces immobility time in the 4-SLIM test. There has only been one other study assessing the antidepressant efficacy of dextromethorphan in vivo. This study came out last year and was actually published 1 week after I applied for my grant, which was just a knife in my heart, but it's okay. Additionally, dextromethorphan is already used clinically in the form of Nuedexta, which is a combination of dextromethorphan and an antiarrhythmic agent called quinidine, which is only used as an enzyme inhibitor to boost blood concentrations of dextromethorphan so that way it weighs less on a patient's body. And this drug Nuedexta is used for a psychiatric condition called pseudobulbar affect. It's also known as emotional lability. It's characterized by spontaneous laughing and crying without appropriate social cues. So this stuff is already being used clinically. Now what I want to see if it can be used clinically for major depressive disorder in human beings. And interestingly enough, at Mount Sinai Medical Center in New York, Dr. James Murrow is experimenting with this drug in a phase 2 trial for treatment-resistant depression. So we're going to find out if this stuff works in humans, and I couldn't be more excited to find out. This study is expected to finish in June of 2015. So, where will future research take us? I hope that future research will, of course, with the end result, allowing us to treat depression better. Because by the rule of thirds, we're not doing a very good job. And I hope that pretty soon we can treat patients that are suffering with major depressive disorder, and we can reduce the burden that it is on our society. And of course, hopefully we can illuminate the basic mechanisms in the brain of how these things work, so that way we can improve our basic knowledge of the brain while improving our clinical treatments. These are my references. And this project was funded by an FAU grant along with my PI, Dr. Robert Verdes. I'd like to acknowledge him, Dr. Stephanie Lindley, and Dr. Sayla Isgor for providing excellent counsel during this project. Salome Sanchez for providing the camera and tripod that I did for all the recordings. All of my lab mates and my 2 best friends for supporting me emotionally through this very tough project. Thank you very much for your attention. Are there any questions?
Sure. You said that the 1 clinical trial is already going on. Do you think, from your observations, statistically significant is important, but clinically significant is much more important?
The thing is that ketamine, the other NMDA antagonist, similar to dextromethorphan, has been used for 15 years, and it has shown statistically significant effects in humans. Not just that, not only is it effective, but it starts taking effect after the first dose, rather than conventional treatments which take between 3 and 8 weeks to even start working. And the fact that this drug, dextromethorphan, has a greater affinity for all the neural mechanisms wherein ketamine exerts an effect, I don't see any question in my mind that this stuff will be even more effective than ketamine, and hopefully will improve our arsenal in treating major depression.
You said it has a greater affinity for all of the things that ketamine has an affinity to, but do you think that could also lead to adverse side effects in addition to the positive effects of the drug?
There is a lot of work already with this stuff being used for glutamate excitotoxicity, because when you suppress NMDA activity, you're suppressing glutamatergic activity, and the drug is also a drug of abuse. So we do have a very large database of case studies to know when someone overdoses on this drug, and the doses that are being used in the clinical trial currently have been shown to be very safe thus far. And that's also why they're using quinidine in combination in the form of Nuedexta, because you can administer quinidine and it can boost blood concentrations and cerebrospinal fluid concentrations of dextromethorphan so that it weighs less on the body metabolically and so forth. Any more questions? Thank you very much.